Okay, picture this. You're, uh, you're vibrant, you're active, you're engaged with the world. But all of a sudden, society starts treating you a little differently. And it's just because you hit a certain age. It's a reality so many older adults face. And it's why understanding geriatric medicine is so crucial, especially now with lifespans increasing globally. Huge thanks to London Heartbeat's Vid Academy in the UK for giving us the material for this.
How our bodies adapt and cope with these changes. And of course, the medical field of geriatrics, which specifically focuses on the health of older adults.
And even the language that we use around aging, I think, is so important. The source points out that words like senescence, senility, senium, alluria, they all relate to getting older, but they have such different shades of meaning. Senescence, that sounds very clinical,
Yeah.
focusing on biological processes. But then you have a word like senility, and that carries often a negative connotation,
Right.
implying cognitive impairment.
Exactly. And then there's this whole concept of age itself. We tend to think chronologically how many years you've been alive, but the source reminds us there's also your biological age, which reflects how healthy and functional your body is, and then your psychological age, which is how old you feel, mentally and emotionally. So you could be 70 chronologically, but feel much younger in these other ways.
Yeah, I know people like that. And even within chronological age, there are subcategories. The source mentions the young old, that's 65 to 74, the middle old, 75 to 84, and the old, 85 and older. And get this, it even throws in these terms like set old age, and ripe old age.
I love those descriptions. It's like even the language itself recognizes that even within the older adult group, there's such huge diversity. Ripe old age, I mean, that sounds much more positive and vibrant than simply old.
Yeah, it does. It speaks to the potential for continued growth and fulfillment, even in later life. Now, let's rewind the clock a little bit and explore the historical roots of geriatric medicine. The word geriatrics comes from the Greek words geros, meaning old age,
Yeah.
and iatric, meaning relating to the physician. So right there in the name, you see the intent to create a specific medical specialty that's dedicated to the challenges of aging.
It really highlights that for centuries. There's been this recognition that older adults have these unique healthcare needs that require specialized attention.
Exactly. Now, the history of geriatrics goes way back to ancient Greece, with observations from Hippocrates and Aristotle. But the term geriatrics was coined by Ignatz Nascher in 1909, when he published a paper on the topic. And he followed up with a textbook in 1914. And today, he's considered the father of geriatric medicine.
He was a true pioneer, paving the way for a whole new field of medicine. But it's important to remember, establishing a new medical field is never easy. These pioneers faced skepticism and resistance, even ridicule.
Absolutely. They had to challenge those prevailing attitudes and prove that older adults deserve that specialized care. And speaking of pioneers, the source introduces us to Marjory Warren. She is a British physician who made incredible strides in geriatric medicine.
Her work at the West Middlesex Hospital was truly groundbreaking. Faced with these overcrowded wards and limited resources, she dramatically reduced the number of beds in her ward, focusing instead on rehabilitation and early discharge. And the results were remarkable. She saw a significant increase in patient turnover and demonstrated that specialized care could actually make the whole system more efficient.
That's a crucial insight. It wasn't just about doing the right thing for the patients. It was about showing policymakers that geriatrics could actually save money and improve hospital flow.
Exactly. And her work really caught the attention of the health minister at the time, who recognized the potential of her approach. And she became a very powerful advocate for geriatric medicine, inspiring others to follow in her footsteps.
And the momentum continued. With the launch of the first geriatric service in the UK in 1947, this was a major milestone, marking the formal recognition of geriatrics as a specialty within the NHS.
And a few years later, in 1949, N. Exton Smith emerged as another key figure in the UK. He advocated very strongly for the specialty, focusing on medical management, rehabilitation, and long-term care for older people. And he worked with Lord Amelry, who was a civil servant, to really champion the field within the British NHS.
It's amazing how these dedicated individuals really shaped the course of healthcare. And Exton Smith, he achieved so much. He became the first English professor of geriatric medicine. And he worked with Doreen Norton, a pioneer in gerontological nursing, who developed the Norton scale, which is a tool for assessing pressure ulcer risk.
He also had this very keen understanding of the bigger picture. He realized that earlier discharges from these specialized geriatric units actually created more beds for other specialties, making the case for geriatric medicine even stronger.
That's brilliant. He showed that investing in geriatrics could benefit the entire healthcare system, not just the older patients.
Absolutely. And his contributions didn't stop there. He also founded the first memory clinic and pioneered early ripple mattresses, which helped to prevent pressure ulcers. He was a true innovator.
Now let's talk about Lionel Cosen. He was a general surgeon with this fascinating background in treating war casualties, and he applied this expertise to geriatrics, establishing the Geriatric Day Hospital in Oxford in 1957.
He really challenged this prevailing assumption at the time that older adults couldn't benefit from rehabilitation. He believed in getting patients moving, even those with hip fractures, and his approach proved incredibly effective.
Yeah, this very practical can-do attitude. He once said, "The first step in rehabilitation is the first step," emphasizing the importance of action and a positive mindset.
And his Geriatric Day Hospital became a model for others, inspiring similar programs around the world. It was a real game changer in geriatric care.
And then we have Bobby Irvine, who partnered with an orthopedic surgeon, who actually recognized his own limitations in treating older patients. And they teamed up to create this world-renowned orthogeriatric unit, proving that collaboration is so key.
They focused on mobilizing even the frailest patients, really shattering this myth that age was a barrier to recovery. Irvine's work showed that with the right approach, even older adults with these complex orthopedic problems could regain their mobility and independence.
So what can we learn from these pioneers? The source highlights several key lessons. Challenging assumptions is crucial. We can't just assume that older adults won't benefit from certain treatments or interventions.
And therapeutic nihilism, this belief that older people can't benefit from treatment, was a huge hurdle at the time, and it took pioneers like Marjory to prove that wrong.
Absolutely. We need to approach geriatric medicine with an open mind and a willingness to try new things. The source also emphasizes developing an evidence base for geriatric intervention.
It's not just about anecdotal evidence. It's about conducting rigorous research to demonstrate that the treatments are effective. And this evidence is so crucial for advocating for funding and support.
Absolutely. We need to show policymakers that geriatric medicine is a worthwhile investment.
And mentorship and teaching are vital as well. These pioneers didn't just make discoveries. They shared their knowledge and inspired future generations of geriatricians.
It's about passing the torch and ensuring the field continues to grow and evolve. And finally, the source emphasizes engaging stakeholders, politicians, civil servants, healthcare administrators.
Geriatric medicine can't exist in a vacuum. We need to work with others to create a healthcare system that really supports the needs of older adults.
It's about building partnerships and advocating for policies that promote healthy aging and quality care. Now, the source acknowledges that the field of geriatric medicine faced significant challenges during this expansion phase. There was this push to move older people out of hospitals and into the community, but often without adequate alternative services in place.
This created a real dilemma. The goal was to reduce hospital stays and promote independence, but without the necessary community support. Many older adults ended up back in the hospital. It really highlighted this need for a more integrated approach to care.
Exactly. And the source notes that UK geriatrics became largely hospital-based, requiring complex negotiations with primary care organizations to provide what they called intermediate care for those older adults who needed more than just home care, but weren't sick enough to be in the hospital.
So it was this patchwork system that often fell short of meeting the complex needs of older adults.
And despite this growing evidence base, for interventions like comprehensive geriatric assessment, there was a real lack of interest in geriatrics among some healthcare professionals.
Some general practitioners felt that geriatrics was already covered by what they did and didn't really see the need for a separate specialty.
So they were saying geriatrics, oh, that's just what I do every day. But I think that perspective really misses the mark.
Absolutely. While GPs play a vital role in primary care, geriatric medicine requires a deeper understanding of the physiological, psychological, and social changes associated with aging. It's about recognizing this interconnectedness of these factors and developing tailored care plans.
And to make matters worse, there were these funding issues. These service frameworks that were designed to support older people were often underfunded, and hospitals were incentivized to focus on acute care rather than the needs of these frail, complex older patients.
It was a system that prioritized efficiency and cost-cutting over the holistic needs of older adults.
The source paints a pretty bleak picture, suggesting that older people in hospital beds were often seen as a problem for the system, rather than the main customers that they actually were.
This speaks to this underlying ageism that was, and sadly still is, prevalent in our healthcare systems and in society at large.
It's a mindset that needs to change. We need to see older adults as individuals with diverse needs and contributions, not as burdens on the system.
Absolutely. And this negative perception extended to the healthcare workforce as well. The source mentions that many medical students, doctors, and nurses expressed a reluctance to work with older people.
That's disheartening. You would think with the aging population, more people would be drawn to this field.
Well, it seems there's still this perception that working with conditions like dementia, incontinence, frailty, it's not as sexy as some other medical specialties.
Yeah, it's a real shame. These conditions are incredibly common in older adults, and they have a huge impact on quality of life.
Yeah.
We need passionate and dedicated people working in this field.
And the language that was used to describe these older patients didn't help either. The source mentions that even those with treatable conditions were labeled as having social admissions or acopia or bed blocking, further dehumanizing them and diminishing the importance of their care.
It's almost like they were seen as inconveniences, rather than individuals deserving of respect and quality care.
And the source quotes Dr. Felix Silverstone, who argued that many doctors were turned off by geriatrics because they didn't feel equipped to handle the complex needs of these older patients. He used the analogy of an old crock to describe these patients, suggesting that geriatricians were often left to deal with the most challenging cases.
That's a provocative analogy.
Mhm.
But I think it highlights this perception that geriatrics is somehow a lesser specialty, dealing with these leftover patients.
And this perception trickles down to medical students, who are often not inspired by the image of geriatrics. It's a vicious cycle that needs to be broken.
So with all these challenges, is there even a case to be made for geriatric medicine?
The source makes a very compelling argument, starting with this undeniable demographic shift that's happening globally. Older people are becoming the main consumers of healthcare, and this trend will only accelerate in the coming years.
We can't ignore the numbers. Geriatrics is not a niche specialty. It's becoming central to the future of healthcare.
Exactly, and it's not just about quantity, it's also about complexity. The source points out that older patients often present with frailty, multiple long-term conditions, disability, all requiring a very specialized approach to care. This makes geriatrics essential, not marginal.
It's about recognizing that older adults have these unique needs that require a unique set of skills and knowledge.
And the source doesn't just make a theoretical argument. It also highlights the strong evidence base for interventions in geriatric medicine, emphasizing that if we apply what we know, it's a win-win for both the patients and the entire healthcare system.
It's about improving quality, access, capacity, and cost. It's about doing the right thing for these patients and making the system work better for everyone.
The source argues that we need to be more vocal, even unreasonable at times, in advocating for geriatric medicine.
Sometimes it takes a little disruption to get people's attention and drive change. But let's get specific about the challenges posed by these long-term illnesses. The source highlights some pretty staggering statistics. 80% of GP consultations, 80% of hospital days, 70% of admissions, and a whopping 70% of health spending are all attributed to older patients.
Those numbers really drive home the point that we need to rethink how we deliver healthcare to this population. The current system is simply not sustainable.
And it gets even more granular. 10% of inpatients account for 55% of bed days, with the top 5% of patients accounting for 40% of bed days. That's a small proportion of older adults, utilizing a disproportionate amount of resources.
This highlights this need for more targeted interventions and more proactive care management. To address the complex needs of these high utilizer patients, the source even suggests exploring models like Evercare pilots, case management, community matrons, as potential ways to deliver more effective care.
It seems like these models emphasize coordinating care and providing more support to older adults in the community, which could potentially reduce those unnecessary hospital admissions.
Exactly. It's about shifting from a reactive episodic approach to a more proactive and integrated model of care that emphasizes prevention and early intervention.
Now, the source introduces us to what it calls the Geriatric Giants. These are the common conditions that affect older people. These include falls, confusion, pressure sores, immobility, depression, incontinence, vision and hearing impairment, and frailty.
These conditions often go hand in hand. For instance, a fall can lead to immobility, which then contributes to depression and pressure sores. It's this complex interplay of factors that geriatricians need to navigate.
And falls are a huge problem. The source states that 30% of people over 65 fall each year. And falls are the most common reason for emergency attendance in this age group. It's a major public health issue.
They can lead to fractures, head injuries, loss of independence, and even death.
The source doesn't let up on these statistics either. Fractures are also common, with 1 in 2 women and 1 in 12 men over 65. experiencing fractures each year in the UK.
That's a staggering number of fractures, and they really highlight the importance of addressing osteoporosis and implementing fall prevention strategies.
Then there's incontinence. The source notes that 24% of those over 65 experience it, and that rate goes up to 40 to 60% in institutions.
Incontinence can have a devastating impact on quality of life. It can lead to social isolation, embarrassment, even depression.
Then we have dementia, another major concern. With 40% of those receiving long-term care affected, it's also a common cause of emergency admissions for those over 65.
Dementia is a devastating condition for both individuals and their families. We need more research, better treatments, and more support for caregivers.
The source also mentions delirium, which is characterized by acute confusion and altered mental status. It's incredibly common in hospitalized older adults.
Delirium is often overlooked or misdiagnosed, but it's so important to recognize it early and address the underlying causes, which can range from infections to medications.
And finally, there's stroke. The source notes that 85% of those affected by stroke are over 65.
Stroke is a major cause of disability in older adults, and it often leads to multiple other health problems. We need to focus on stroke prevention, early recognition, and access to specialized stroke care.
Now let's dive a little deeper into frailty. The source defines it as a failure to integrate responses in the face of stress, leading to this decline in function, and increased vulnerability to problems like falls, immobility, and delirium.
I think that definition is really interesting because it moves beyond just seeing frailty as weakness or physical decline. It highlights this reduced capacity to bounce back from these stressors that makes older adults so susceptible to a cascade of negative events.
Like they're walking a tightrope, and even a small gust of wind can knock them off balance.
Precisely. And the source actually provides a visual representation of the stages of frailty, starting with healthy aging, then progressing to chronic vulnerability, then acute illness, and finally recovery. But what's really striking is how this visual depicts the decline in health status. An acute illness can cause a very steep drop in function, making it much harder to recover and return to those previous levels.
It's a stark reminder that frailty is a dynamic process. Even a seemingly minor illness can have a significant impact on an older adult's health trajectory.
And the numbers are concerning. Frailty syndrome affects a substantial portion of community-dwelling elderly, and the risk increases dramatically with age.
That's a worrying trend. We need to be able to identify and address frailty early on before it leads to more serious problems.
And what's fascinating, the source points out that people who frequently use hospitals often experience this combination of physical and social vulnerabilities. It's not just their medical problems, it's also factors like isolation, poverty, lack of support.
It's a reminder that health is about more than just biology. Social factors play a huge role, especially in older adults.
The source then shifts its focus to a very specific example: hip fractures in the NHS. It highlights this very high incidence of these fractures, which are a major cause of hospitalization and long-term care placement.
Hip fractures really do epitomize those challenges of geriatric care. They're often the result of multiple interacting factors: falls, osteoporosis, other underlying health conditions.
And they can have a devastating impact on function and independence.
The source even challenges the existing system, asking whether orthopedic surgeons are even the best equipped to care for older adults with hip fractures. It's a provocative question. That raises some important considerations about how we organize and deliver care.
It's about thinking outside the box and exploring new models of care that better meet the needs of older adults.
And speaking of new models, the source then dives into this growing evidence base for effective interventions in geriatric medicine, with comprehensive geriatric assessment, or CGA, taking center stage.
CGA is this multidimensional, interdisciplinary process that goes beyond just treating the immediate medical problem. It's about assessing medical, psychological, and functional capabilities to really create a tailored care plan.
And the evidence is impressive. Studies show that CGA can reduce mortality, increase the chances of living at home, and improve physical and cognitive function.
That's right. And it's not just short-term benefits either. Newer data suggests that CGA can have a positive impact in the long term as well.
It's about looking beyond that immediate crisis and focusing on those long-term outcomes, like independence and quality of life.
And the source emphasizes that even if CGA doesn't always reduce long-term mortality, it still provides valuable information that can guide future service developments.
It's about using data to drive innovation and create a more responsive healthcare system.
But CGA is not the only success story. The source also highlights the effectiveness of specialized stroke units. in reducing mortality rates among stroke patients.
It's another example of how that focused expertise can make a real difference in those patient outcomes.
And there have been significant advances in managing delirium as well. Targeted interventions have shown really promising results in reducing both the incidence and duration of delirium in these hospitalized older adults.
That's encouraging. Delirium can be such a frightening and disorienting experience.
Yeah.
And to have effective treatments, that can have a huge impact on recovery.
And let's not forget about falls prevention programs, which have demonstrated this remarkable reduction in falls.
These programs are often individually tailored, addressing specific risk factors and providing those personalized interventions.
And the source also highlights the success of falls clinics, which offer these comprehensive assessments and advice to help older adults reduce their risk of falling.
And these interventions are often cost neutral, meaning they don't add a significant financial burden to the system.
It's a win-win situation. We improve patient care, and we save money in the long run.
The source makes this powerful point. That getting treatment right isn't just about benefiting the patients. It's about improving the entire healthcare system. It uses historical examples to illustrate this point, mentioning Marjory Warren's work in the 1940s, which improved patient flow and reduced bed occupancy.
It's about seeing geriatric medicine not as a drain on resources, but as a way to make the system more efficient and effective.
The source then zooms out to look at this global picture of aging. And the statistics are eye-opening. The world's population is aging rapidly, and the majority of older adults will soon be living in developing countries.
This is a global challenge that requires global solutions. We need to share knowledge, resources, and best practices to ensure that older adults everywhere have access to quality care.
So with this global perspective in mind, the source addresses a key question. Why are there still arguments against specializing in geriatrics?
Yeah, it does seem counterintuitive, but the source acknowledges these negative attitudes and perceptions that persist. This perception of geriatricians as third-rate doctors continues to be a barrier, making it hard to attract medical students to the field.
It's like a self-fulfilling prophecy. If we don't value geriatric medicine, we're not going to attract the best and brightest to the field.
We need to change the narrative. We need to highlight this vital role that geriatricians play in improving the lives of older adults.
And the source emphasizes that. Geriatric medicine isn't just about treating diseases, it's about improving function and quality of life. It's about recognizing that aging isn't just about decline, it's about resilience and adaptation.
Geriatricians are the experts in aging, and they bring such a unique perspective to healthcare. They understand the complex interplay of these physical, psychological, and social factors that influence the health and well-being of older adults.
So what does the future hold for geriatric medicine?
Well, the source acknowledges this evolving landscape of healthcare, noting the trend towards more hospital-based care and the emergence of subspecialties within geriatrics, such as stroke care.
This raises some important questions about how these different areas will collaborate to provide that seamless and comprehensive care for those older adults with those complex needs.
We need to make sure that these older adults don't fall through the cracks as the system becomes more specialized.
And technology is going to play a huge role in the future of geriatric care. Think about telehealth, remote monitoring, assistive devices. These advancements can help older adults age in place and maintain their independence for longer.
It's an exciting time to be involved in this field, but we also need to be mindful of the ethical implications of these technologies and ensure they don't create new forms of inequality or exclusion.
Now let's zoom in on some specific geriatric syndromes and conditions that geriatricians often encounter. In both the hospital and outpatient settings, the source lists several, including dementia, delirium, depression, inappropriate medications, gait and mobility impairment, incontinence, iatrogenic complications, osteoporosis, falls, hearing and vision impairment, sleep disorders, failure to thrive, and medication-related issues.
Wow, that's quite a list. It really highlights the breadth of knowledge and expertise that's required in geriatric medicine.
And these conditions often present atypically in older adults, making diagnosis more challenging.
For example, an older adult with pneumonia might not have the typical fever and cough. Instead, they might just seem more confused or weak.
That's why it's so important for healthcare professionals to have that high index of suspicion when working with these older adults and to consider a wider range of possible diagnoses.
Absolutely. We can't just assume that symptoms are due to old age.
So how do we approach the older patient? Where do we even begin?
Well, the source provides some excellent guidance, starting with this simple but crucial message: don't be ageist.
It sounds obvious, but ageism is pervasive in healthcare, and it can lead to biased care and misdiagnoses.
We need to approach every older adult with respect, with empathy, and with an open mind.
The source also emphasizes the importance of patience during that history-taking. It might take a little longer to gather information from an older adult, but it's so essential to give them the time and space they need to share their story.
It's about listening attentively and recognizing that these older adults are the experts on their own lives.
And clear communication's key. Speak slowly, use plain language, and ensure that the patient can hear and see you properly.
We need to create this comfortable and safe environment where the patient feels respected and heard.
And don't forget about those practical considerations, like obtaining a complete medication list, assessing family cooperation and caregiver stress, and addressing any safety concerns.
These are all crucial aspects of providing that holistic and patient-centered care.
And the source highlights the ethical issues that often arise in geriatric care.
End-of-life decision-making, navigating those complex family dynamics, advocating for the patient's best interests. These are challenging situations that require sensitivity, compassion, and a very strong ethical compass.
And we can't ignore the role of healthcare financing, particularly Medicare.
We need a system that adequately supports the needs of older adults.
Absolutely. And finally, the source reminds us to be culturally sensitive. Cultural beliefs and practices can significantly influence health behaviors and preferences for care.
It's about recognizing that one size does not fit all in geriatric care. We need to tailor our approach to the individual patient's cultural background and values.
Now, the source circles back to those geriatric syndromes we talked about earlier, providing more details on their presentation, diagnosis, and management. So let's start with dementia, depression, and delirium, which are all common in hospitalized older adults.
The source emphasizes the importance of cognitive screening, asking about those depression symptoms, and assessing orientation and concentration.
So it's about being proactive and identifying those conditions early on.
And it's crucial to really distinguish between delirium and dementia. Delirium often involves fluctuating levels of consciousness and attention, whereas dementia typically has this more gradual and progressive decline in cognitive function.
Now, let's talk about incontinence. The source reminds us to consider those different types of incontinence, like stress, urge, and overflow, as this can guide treatment decisions.
And it's important to rule out urinary tract infections, which can mimic incontinence symptoms in older adults.
Osteoporosis is another very common problem, particularly in older women.
The source reminds us about the importance of calcium and vitamin D supplementation for bone health and highlights the availability of effective medications to reduce fracture risk.
Falls are also a major concern. And the source really emphasizes the importance of a comprehensive falls assessment, including assessing gait, balance, and sensation.
And we shouldn't forget about hearing and vision impairment.
Right, those can really impact quality of life and independence.
Absolutely. Simple assessments like a whisper test for hearing and a vision check with the glasses on can go a long way in identifying and addressing these problems.
Sleep disorders are also common in older adults, often contributing to daytime fatigue and other problems.
The source suggests inquiring about sleep habits. Expert speaker. The source suggests inquiring about sleep habits, exploring potential causes of sleep disturbances, and offering practical solutions, such as avoiding alcohol and caffeine before bed.
And failure to thrive is a concerning syndrome that requires a thorough evaluation to identify any underlying medical, social, or psychological issues.
It's about recognizing the signs of decline and intervening early to prevent further deterioration.
And finally, we need to be vigilant about iatrogenic complications, particularly those caused by medications.
Polypharmacy is a major concern in older adults, and it's crucial to review medications carefully, considering potential side effects and interactions.
The source specifically warns about anticholinergics, which can worsen confusion and delirium, and reminds us to prescribe laxatives when using narcotics to prevent constipation.
It's about anticipating potential problems and taking steps to prevent them.
The source also mentions other medications that can be problematic in older adults, including antiarrhythmics, Dilantin, neuroleptics, and proton pump inhibitors.
It's about being aware of the potential side effects of all medications and monitoring older adults closely for any adverse reactions.
And lastly, the source highlights the dangers of prolonged bed rest, particularly during hospitalization, which can lead to rapid muscle loss and functional decline in older adults.
Immobility is a major threat to healthy aging. We need to encourage early mobilization and rehabilitation to help older adults regain their strength and independence.
The source even quantifies this risk, stating that older adults over 80 can lose one activity of daily living for every 3 to 5 days of bed rest.
That's a powerful image that really drives home the importance of keeping older adults moving.
And with that, let's move on to the next part of our deep dive, where we'll explore some common diseases in older adults and delve into the concept of comprehensive geriatric assessment.
Yeah, it's amazing how quickly that can happen. Now, shifting gears a bit, the source dives into a pretty comprehensive list of common diseases that affect older adults. And it's a pretty diverse range, from neurological conditions like Parkinson's disease and stroke, to cardiovascular issues like atrial fibrillation and heart failure, to endocrine conditions like diabetes and hypothyroidism.
Yeah, it's a reminder that geriatricians really need to be well-versed in a wide range of medical conditions and understand how those conditions might present differently in older adults.
Exactly. We can't just focus on one organ system or one disease in isolation. We really have to consider the whole person and this interplay of multiple factors.
Now, the source introduces this concept that I thought was really intriguing. It's the first rule of geriatrics. And they compare it to the first rule of real estate. Location, location,
Yeah.
location. They say the first rule of geriatrics is function, function, function.
I love that analogy. It highlights that for older adults, maintaining their function is really key. It's about being able to do the things that matter most to them, whether it's walking to the mailbox, cooking a meal, or spending time with loved ones.
The source makes a really powerful statement. It says, patients don't care about their diagnoses, they care about their function.
So true. They want to know, will I be able to walk again? Can I still live independently? Will I be able to dress myself? Those are the questions that really keep them up at night.
And this emphasis on function really shapes the goals of geriatric medicine. The source outlines those goals as maintaining health in old age, detecting and treating disease early, maximizing independence despite any limitations, and providing compassionate care during that terminal illness.
It's about recognizing that aging is a journey, not a destination, and really supporting older adults through every stage of that journey.
And the source brings us back to comprehensive geriatric assessment, or CGA as we've been calling it, as a cornerstone of this approach. It defines CGA as a multidimensional, interdisciplinary diagnostic process. That helps us really understand the medical, psychological, and functional capabilities of an older person.
Like piecing together a puzzle, right? CGI helps us see all those pieces, medical, psychological, functional, to really create this full picture of the patient.
And the source really stresses that CGA is crucial for patients with frailty, functional impairment, and multiple long-term conditions. It's really what defines what geriatricians do.
It's about seeing the whole person, not just a collection of diseases or symptoms.
And as a reminder, the key areas to assess during CGA include activities of daily living, or ADLs, like bathing and dressing, instrumental activities of daily living, IADLs, like managing finances and transportation, mobility, incontinence, affect and mood, and cognition.
These assessments really give us this comprehensive understanding of the older adult's functional status and help us to really tailor interventions to their specific needs.
Now, as we wrap up this deep dive into geriatric medicine, the source doesn't shy away from those ongoing challenges. It highlights the persistence of negative attitudes towards older people, the need for better training for healthcare professionals, and the all-too-common breaches of dignity experienced by older adults in healthcare settings.
These are really sobering reminders that we still have a lot of work to do.
It's about advocating for a healthcare system that truly values and respects older adults.
And it's about each of us examining our own biases and challenging ageism wherever we see it.
The source ends with this powerful question. It says, so can you learn anything from us at all? And way. It's really a challenge to us to reflect on our own knowledge and understanding of aging, and to consider our role in shaping the future of geriatric care.
It's a call to action, urging us to be lifelong learners and advocates for older adults.
I think it's a fitting way to end this deep dive. Geriatric medicine is a field that's constantly evolving, and there's always more to learn. But I think one thing is clear. This field matters. Older adults deserve compassionate, comprehensive, high-quality care. And by working together, we can create a healthcare system that truly meets their needs.
I couldn't agree more. It's been a pleasure exploring this topic with you.
Likewise. Huge thanks again to London Heartbeat's Ec Academy in the UK for providing the source material for this incredibly insightful deep dive. And to all our listeners, be sure to subscribe to the Deep Dive on Facebook, Instagram, Spotify, and YouTube so you don't miss out on any future episodes. We've got some fascinating discussions lined up, so stay tuned. Until next time, keep diving deep and keep learning.